last speaker is Dr. Michael Kanter, who, by the way, drove down from Encino this morning. A heroic figure in Southern California terms. He has been the Southern California Permanente Medical Group Medical Director of Quality and Clinical Analysis since January 2004. In that position, he is responsible for regional coordination and support of medical care programs, for quality assessment improvement, technology assessment, clinical practice guidelines development, population care management, member health education, continuing and graduate medical education, and clinical research activities for the Southern California Kaiser, which serves 3.5 million members. He's a pathologist by training, and he's authored multiple publications in peer-reviewed journals, and he's a frequent speaker on healthcare systems at IHI and other places, and we welcome him this morning.
Thank you. It's great to be here, and I've actually never been to one of these conferences. This has been really good. I've really enjoyed listening to the other speakers and learned a lot. So I'm going to talk for hopefully under 20 minutes, or I'm going to get the hook probably, but I want to have time for questions. The way I sort of think about physician shortages is really in the context of all of the other issues we're facing, and very specifically after yesterday at some meetings where we found the new Medicare cuts, so we've got some very large budget constraints and reimbursement issues. At the same time, we have to provide access to patients, again, under the lens of a lot of regulators from DMHC. We've got purchasers looking at quality and cost. So we got to balance quality, service, access, and cost. And I think that's the right context to then look at, do we have enough of workforce and how we're going to deal with that. So the way I sort of look at workforce really is there's a couple levers to pull. One is simply to hire more people into our system. But really the better way, that would obviously not fit so well with cost issues. Really the issue is, can we decrease the demand for physician services by evidence-based guidelines, by preventive care? The other thing is, can we increase the efficiency of our physicians? And I'm going to talk both about increasing physician and about decreasing demand for physician services. And I think all of these things are aligned with cost containment and affordability and providing service and access. So a little bit about Kaiser Permanente. Integrated delivery system. We're actually up to 3.6 million members. We've grown since I filled out the information. We're covering Southern California as our region. About 6,000 doctors, pharmacy, lab, radiology, hospital, outpatient is all in one system that's integrated with connection by an electronic medical record. So let me move forward then. I'm going to first talk about what we can do about demand for physician services. So this is our hypertension control rates. These are HEDIS specifications for the physician technocrats in the room. We're right now at 85.5%. We actually started in 2004. We were around 50% control rate. For every patient we bring under control, we only need to bring in 36 to actually save a heart attack or a stroke. That's based on literature. So you can kind of do the math. If we've got 600,000 patients with hypertension and we've increased our control rates 20% in the last 5 years, how much that saves in terms of heart attacks, strokes. To me, this is huge. When we have gone through our calculations, we think over the next decade, this will save about 5,000 lives. If one extrapolated that to the country, we're roughly 1% of the country. So potentially 500,000 lives in the United States could be saved by achieving an 85% control rate. We did start at about average. How many physicians will save by this? I don't know, but I think it's a lot. Key point on this, I could talk for a few hours on how we do this. The medical home, I think, is an interesting concept, but one of the things we've leveraged is specialty care. So for those of you who are Kaiser Permanente members, if you walk into essentially any specialty clinic in our system and have not had your blood pressure checked recently, it will get checked and recorded, and if it's high, somebody will follow up. So just relying on a primary care doctor's office, in my view, misses a lot of opportunity for good care here. There's lots of other things we've done with this. I can just tell you very small disparity between African Americans and Caucasians, very small disparity between Medi-Cal and commercial and Medicare. We've put in systems to make this highly reliable so that pretty much everybody has the same chance of getting under really outstanding control. CDC has been pushing this with their Million Hearts campaign. Another way we can, I'm going to just give a few examples of things we can do to make our doctors less needed and more effective. Foot exams doesn't sound particularly like a great breakthrough in innovation. Our foot exam rates have gone up, whatever that is, I guess it's about 30%. And why is that important? Hopefully the next slide will come in. Well, our foot amputation rates are going down. Another big savings here. One of the ways, this is going to sound very silly to do this, but when you check into one of our offices, a computer checklist comes up. We call it the proactive office encounter. It lists all of the care gaps that patient has based on evidence-based protocols. If you're a diabetic and you haven't had a foot exam in a year, the office staff is instructed to take your shoes off. Sounds pretty low-tech and simple, yet that's a huge barrier. And if you have to have 300,000 diabetics coming in with a physician in the middle of an exam saying, gee, you got to take your shoes off, and all of that time spent doing that, and when the physician's standing there, it's just simply not efficient. So it's a way to make the doctor more efficient, saving on the amputations. Again, last example I think I have here, colorectal cancer screening. This is another preventable disease. If you actually look at our incidence per 1,000 members, it's going down from 0.57 to 0.37 per 1,000 members over a relatively short period of time. We started a massive screening program in around 2005. Our number of colectomies we're doing is down about 800-900 over the same time period. And most of our screening, it says, is taking doctor time. About half of our screening is done through the mail. We're very proud of the fact that we mail more stool through the U.S. mail than any other organization. If you're a Kaiser member and you're over 50 and you haven't been screened, I don't know if there's anyone like that in this room, but you get hounded literally every office visit, every email. We do it through letters, phone calls, etc. And we're really pushing this aggressively. So we think there's a lot of, again, savings here in both doctor and cost. Now, one of the things you need to look at is not only can we do preventive care and other care that decreases the need for future services, can we make our docs more efficient? So we started something called the Total Joint Dance, which was a way to increase throughput for joint surgery. And we actually, by using lean principles and parallel processing of processes and value stream mapping, we're able to remove waste from our OR, have standard trays, standard protocols for when the surgeon does what in the OR. We're able to increase the number of cases we could do, cut the turnaround time in between procedures. The surgeons actually don't operate faster. It's just all the waste in between cases is really what we knocked out of this thing. freed up a huge amount of physician time and OR time. A couple other things I'll just mention. Somebody mentioned the readmission issue here. This is a huge opportunity that we're working on, but think about all of the wasted physician time by having people with multiple readmissions into the hospital. We started an interesting program. People talk about obesity. We're actually starting a formal program in which specialists as well as primary care doctors will be sending patients with BMIs over 30 to weight management programs. We have the ability to measure this, track this. Our weight management programs are associated with about a 5% weight loss. We're able to measure this and track that as well. Our researchers are lined up to actually measure decreases, hopefully, in utilization when this happens. People have looked at obese people. They tend to use more services, but I don't think there's a lot of data on what happens if you take an obese person and make them less obese. How much does utilization change? Pap smears every 5 years. We actually used to do them every year. We went to every 3 years. That saved us 100,000 appointments in our system every year. That's 25 doctors, 30 doctors, something like that, if doctors were to do all those things. When we go to 5 years, we think we're going to save a similar number of appointments. We carefully have been monitoring our cervical cancer stage at diagnosis, and in fact, that has not changed as we have been increasing the interval between screenings, and this is based on a lot of evidence that a lot of folks have agreed on, including the U.S. Preventive Health Task Force. But implementation of these guidelines are actually key. Teleophthalmology, our patients with diabetes get a camera, take a picture of their eye, get read at a reading center. We actually don't need to use providers to see these patients if they're normal photos. It's another huge savings. Let me talk about shared decision making. We actually did a pilot in orthopedics. What shared decision making refers to is really educating patients in a standard way about their treatment choices. Some of the data on this was published by Group Health recently in Health Affairs. What we found in our own internal data with orthopedic surgery, if you put patients in front of a standard video that explains pros and cons of surgery and actually has other patients describe this and what it means to actually have hip pain or have a complication of surgery, the demand for hip surgery went down by about 30%. The patients are more informed by surveys. They're more satisfied with the decision. They feel like they know what they're doing more, including the ones that elected to have surgery. But we don't do a great job. We talk about informed consent and telling people, well, your risk of an infection is 1% and aggravation of arthritis, whatever percent, but that doesn't mean much to patients. And what these sort of standard educational materials do is really explain it in terms of what it actually means to a patient to either get a complication or get better with their surgery. Doctors really don't always know how to explain that well. Office visit return, nobody studied this, but you're a doctor, you see a patient, they've got whatever disease, how often do you bring them back? Nobody does randomized trials or any kind of studies on this stuff. We're starting to look at this. Our hypertensive patients, we actually are trying to get 1 visit a year if they're in control. We think there's a huge opportunity there, but we need to define this with many other diseases. Huge opportunity for research here. It's very easy with something like hypertension where you can easily monitor if that's adversely impacting people or not. So a few more things about physician productivity. Since we're an integrated delivery system, all of our doctors work in offices run by us. So the issue is, can we do things to the office staff to make them more supportive of the physician's practice? So most doctors, they go to medical school, they go to residency, they don't know how to run an office. They just, sort of learn by doing. So we've actually created standard workflows, standard protocols for everything from how to prepare the exam room to how to answer messages. And we've been surveying our physicians year to year. You can see we're doing better. We've got a long way to go in this area. But getting the physician offices more efficient, in theory, should allow us to have more productivity through the physician's offices. Just some more data on that. We're doing it in specialty care, not just primary care. Last thing I wanted to just mention, actually two more things. We have an electronic medical record. Patients can access their own lab and pharmacy data. I don't know how many members are here, but we just created something called an online personal action plan. If you go into your online record, what's unique about this is you actually can see your own care gaps, what care you need, what care you've already had. It's sort of like an automobile. You know, you can go in and look at your maintenance log on your car. Our patients can do this, and they can actually, I believe, self-manage to a large degree because they'll know what they need, when they need it. And there's actually links on there that tells you how to get that care gap filled without necessarily seeing a doctor. And we're planning on developing this a lot more, but it's a way to really create self-management programs that are actually implementable by patients. Last thing I wanted to mention is we train our own residents. Part of our workforce planning is to increase our residency programs, and we're slated to go up by about 70 residents over the next 4-ish years or so. It's a little challenging with Medicare funding for this stuff, but we believe it's an important part of our community benefit. Many of these doctors stay with us, but many of them work outside of Kaiser when they finish, and we actually like that. It is part of our mission to improve the healthcare outside of our own delivery system. So I think this is another thing hasn't been mentioned, is really the whole issue of training more physicians and getting more people in the pipeline. So with that, I think I will stop. Thank you.